All right, let's jump right in. If you're prepping for the ORE Part 1, you know hematology is a big deal. So, in the next few minutes, we're going to cut through all the noise and really zero in on the high-yield, must-know stuff for the exam. Ready? Let's do this.
So let's start with a classic clinical puzzle. Imagine a patient walks into your clinic with these three things: a sore tongue, weird-looking spoon-shaped nails, and they're just exhausted all the time. On the surface, they might seem random, right? But in hematology, they tell a very specific story. Keep these clues in your back pocket, because by the end of this, you'll know exactly what's going on.
Here's our game plan. We're going to start with the basics, what red blood cells are all about. Then we'll get the big picture on anemia and dive into three major types, looking at them like case files. We'll wrap it all up with a rapid-fire review of the dental stuff you absolutely have to know. This whole thing is built for one purpose, helping you remember this on exam day.
First up, erythrocyte essentials. Before we can talk about what goes wrong, we've got to be crystal clear on how things are supposed to work with our body's amazing oxygen delivery service.
Okay, let's break it down really simply. Think of erythrocytes, red blood cells, as little oxygen taxis. Their only job is to pick up oxygen from the lungs and drop it off to all the tissues. They're built in the bone marrow, and the factory gets the go signal from a hormone called erythropoietin, which, fun fact, comes from the kidneys. The star player inside each taxi is hemoglobin, and after about 120 days, they get recycled in the spleen. Simple, elegant, and absolutely vital.
So, what happens when this elegant little system breaks down? Well, that's when we enter the world of anemia.
For your exam, burn this definition into your brain. Anemia isn't just about having fewer red blood cells. The key part is that the hemoglobin level is too low. No hemoglobin, no oxygen transport. That's the core problem. The blood just can't carry enough oxygen to meet the body's needs.
So what does this look like in a real person? Well, they're going to feel tired, obviously, and short of breath. Their heart's going to try to compensate by pumping faster so you get palpitations. And for us as dentists, the mouth is a huge diagnostic billboard. You've got to look for paleness in the gums, a sore mouth, that classic smooth tongue we call glossitis, or even ulcers. These are massive red flags.
Now this is where the detective work really begins. The first and most important clue you'll get from a blood test is something called the MCV, or mean corpuscular volume. It just tells you the average size of the red blood cells. Are they too small, microcytic, too big, macrocytic, or just right? This one number is your fork in the road. It tells you which path to investigate first.
So let's follow that first path, down the road of small cells. We're talking microcytic anemia. And the number one suspect almost every single time is iron deficiency.
Okay, these are the absolute must-know facts. Iron deficiency is the most common cause of anemia worldwide, period. It's usually caused by some kind of slow chronic blood loss or just not getting enough in your diet. Diagnostically, the earliest and best sign is a low serum ferritin. That tells you the body's iron stores are empty. And on a blood film, you'll see those classic small, pale red blood cells.
And here we go. Remember our puzzle from the start? This is koilonychia, or spoon-shaped nails. It's such a classic physical sign. When you see this, alarm bells for iron deficiency should be ringing loud and clear in your head. It's a fantastic visual clue.
Now, the management seems simple, right? Give them iron pills. But here is the key point, and a classic exam trap. You don't just treat until the hemoglobin number looks good. You have to keep the therapy going for at least 3 more months. Why? Because you need to completely restock the body's iron warehouses in the bone marrow.
Okay, screenshot this, write it down, whatever you need to do. This is cure or gold. The dental signs are huge. That sore, shiny red tongue, that's atrophic glossitis. Those painful cracks at the corners of the mouth, angular stomatitis. You might even see recurrent ulcers. And in really severe chronic cases, you have to know about Peterson-Brown-Kelly syndrome because it increases the risk of oral cancer. And here is a perfect picture of what we're talking about. Look at that tongue. See how it's lost all those little bumps, the papillae? It looks smooth, red, and almost beefy. That's atrophic glossitis, a textbook sign of a major nutritional deficiency, very, very often iron.
All right, let's switch gears. We've investigated the small cells. Now, let's look at our second case file, macrocytic anemia, where the red blood cells are too big. And the classic example you need to know is pernicious anemia.
So what's the story here? Well, pernicious anemia is an autoimmune condition. The body basically attacks itself. specifically the cells in the stomach that make something called intrinsic factor. And here's the problem. You need intrinsic factor to absorb vitamin B12. What's tricky is that it comes on so slowly because your liver has massive B12 stores that can last for years. And just like iron deficiency, it has a cancer risk. This time, it's stomach cancer.
Now listen up, because this is absolutely critical. This is what really separates B12 deficiency. It can cause serious, irreversible neurological damage. Patients might complain about pins and needles, that's paresthesia, long before any anemia actually shows up on a blood test. In really severe cases, it can even cause psychiatric issues, which they used to call megaloblastic madness.
So how do we prove the problem is that missing intrinsic factor? We use a classic diagnostic called the Schilling test. It sounds complicated, but it's not. First, you give a tiny, traceable dose of radioactive B12 by mouth. If the body can't absorb it, it won't pass into the urine. Then, you do the test again, but this time you give the B12 times with intrinsic factor. If the radioactive B12 suddenly shows up in the urine, bingo, you've just proved the diagnosis is pernicious anemia.
Okay, let's put these two side by side. Think of this as a quick cheat sheet. Microcytic, low MCV. That's your iron deficiency. Classic sign, spoon nails. Macrocytic, high MCV. That's your B12 deficiency. Classic sign, neurological stuff like pins and needles. They can both give you a sore tongue, but these other features are how you tell them apart.
Now, for our third and final category, hemolytic anemias. This is where red blood cells are getting destroyed faster than the body can make them. And for us as dentists, the one you absolutely need to know about is sickle cell disease.
This slide is your survival guide for safely managing a dental patient with sickle cell. Your #1 job is to avoid triggering a crisis. That means no hypoxia, no dehydration, no infection. For pain, paracetamol is your friend. Stay away from aspirin. For local anesthetic, it's smart to avoid prilocaine. And if there's any hint of infection, you have to get on top of it fast, often with antibiotics before you even start treatment.
Okay, we have covered a ton of ground. Let's take a deep breath and lock in the most important dental points with a final, super high-yield review.
I want you to walk away from this remembering one thing. The mouth is a mirror to the rest of the body. A sore, smooth tongue isn't just a random finding. It should make you think iron, B12, or folate deficiency. Cracks at the corners of the mouth point strongly to iron. Recurrent ulcers could be any of them. And that pale look in the mouth, that tells you the anemia is probably pretty bad.